Bismillah, walhamdulillah, wassalatu wassalamu ala rasulillah. Welcome to our Saudi Anesthesia Society virtual conference for the year 2020. And we are honored today with chairing the first session with my colleague, Dr. Atif Sait, and with our distinguished speaker to talk about Saudi Anesthesia Society protocol for COVID-19 perioperative best guideline practice. Without further ado, it is my pleasure and to present our first speaker, Dr. Abdullah Alharbi. Dr. Harbi is a consultant anesthesiologist and he's the chief of the Department of Anesthesia, Security Force Hospital in Riyadh, Saudi Arabia. He is a fellow of the Australian New Zealand College of Anesthesiologists and a member of Saudi Anesthesia Society. His area of interest anesthesia, training and education in anesthesia, quality assurance in anesthesia practice, and advanced intraoperative monitoring. Dr. Harbi will present today for us the airway management for COVID pandemic. Abdullah, it's a pleasure to have you.
Thank you very much, Dr. Fahad. Assalamu alaikum wa rahmatullahi wa barakatuh. So, before I start, I would like actually to thank you all for being with us on Friday morning and on this lovely weather. You might have other options, but hopefully, inshallah, you'll find some valuable information in this presentation. I would like also to thank the organizing committee for the great effort they have done for this presentation, and also the Saudi Anesthesia Society for their great job in preparing the guidelines early during the pandemic crisis. So over the next 20 minutes, inshallah, I will go briefly over the airway management that the guidelines have been published by the task forces from the Saudi Anesthesia Society on March and April from this year. So no conflict of interest to declare with regard to this lecture that I'm aware of. And the acknowledgement is, as I mentioned, for the organizing committee for their great effort. So the COVID-19 started late last year in China, in Wuhan, and eventually became an unprecedented medical issue and crisis that affected all communities, medical and also non-medical. The WHO declared the pandemic alert on February 2020. So the issues with this unprecedented crisis, there was early in that course, there was uncertainty about the mode of spread, and also there was some uncertainty about the testing and the spread of false negative tests and how much we can rely on the testing. And that led to a panic among medical and also even the general community. There was also a scarcity of reliable data and facts, and that led the social media to be the major part of information sharing and spread from both medical and non-medical community, and that led to confusion between the practitioner actually, so because of a lot of information coming at the same time, and not all of it are reliable. On top of that, there was also international concern about the non-availability and also lack of supply for the protective equipment, and that added to the stress that the healthcare worker had to bear with. The medical journals also lowered because of the crisis. They lowered the bar and facilitated publications of articles, review, and even small case series and centers' experience and pertaining the crisis, which is probably a good initiative, but that led to a lot of information and not all of it also reliable, and maybe clouded the judgment and the decision in some areas. So this is just a brief, if we go to about the SAS initiation. So in December 19, started in China, and we can see that the first report of fatality was in January, in the 1st of January, and then it spread to different areas, starting I think in Japan, Hong Kong, and Korea, and then we reached the pandemic level in February. So within a couple of months, it's almost reached to the pandemic level. The WHO has sent the preparedness and response letter or update on February. And what we actually commend the Saudi Anesthesia Society, they were from the first society, they actually prepared task force to guide the anesthesia practitioner being in the front line, at least to give them some guidance for managing the airway. So there was an editorial in Saudi Anesthesia Society by Prof. Abdulaleem Al Attasi, and also there were in the same special issue of the Saudi Journal of Anesthesia, there was multiple guidelines on different for the general intubation, for general patients, and also for special population. So the airway management in COVID-19 and the Saudi Anesthesia Society prepared by the task force from our colleague, Dr. Alharbi, Dr. Abdullah, and Dr. Qurashi, Dr. Katan, and Dr. Ahmed, and Dr. Dawlatli. And the objectives of these guidelines were mainly to provide an update information about the COVID and also to establish guidelines related to the airway management in patients with suspected or confirmed COVID-19. They also wanted to describe the recommended personal protective equipment suitable for airborne, droplet, and also contact isolation precaution. So they started with the definition for the suspected case, anyone with respiratory symptoms with a history of trouble at that time, and eventually the trouble has been eliminated once we get to the pandemic level. The probable case was the positive symptoms, but was no inconclusive test, and the confirmed cases when we have laboratory confirmation. The contact, the one without symptoms who has just a history of contact with someone with COVID-19. They described the possible route, which is the routes of transmission. So the direct contact and droplets, which is the main, and airborne spread during the aerosol generating process like the intubation. So they actually described in a very good way, starting with the preparation. So they took to the preparation, team dynamics, and also environment. So for the preparation, there was a focus on preparing the PPEs or the protective equipment, and also having to allow the time and to observe the donning and doffing process. And they advised to minimize the number of staff to minimize the exposure, and there should be a clear warning signs around the place that if there is a COVID-19 patient or there is an aerosol generating process like an intubation. And also they emphasize on having a plan on airway management. So if you're anticipating a difficult airway, then what are the requirements, what are the equipment that you might need? Okay. So for the team dynamics, so they put emphasis on the role. So every one from the team members should know his role and exactly and what he's participating in. And they advise the intubation to be led by the expert. So the most senior person should perform the intubation to minimize the time and also minimize the spread. Communication, as always in any crisis or any teamwork, communication and having a closed loop feedback. And they had also cross-monitoring for contamination. So during the donning, someone should watch to make sure there's no breach in donning, and also more important in doffing, so, to prevent occupational spread. So the environment, so we had the advice in the negative pressure room. If available, then the patient should be intubated or perform any aerosol generating procedure in a negative pressure room, and should have a dedicated areas or pathway. Like if the patient is coming to the OR, there should be a specific corridor that should be, we have a sign that the patient is COVID-19 is coming to this area. And then minimize the transfer. So if the patient is being intubated in the OR, to keep him in the OR also for extubation also, and then and not to shift him to the back of a different area. They also describe the equipment and disposal, if possible to use the disposable equipment. And there is also instruction about how can we dispose the infected or contaminated materials. And HEPA filters to be used also all the time with suspected or confirmed cases. So for the process of airway management itself, the description was to start with the ASA standard monitoring, and as mentioned earlier, the expert to lead the airway management, and to have the lowest possible gas flow just to maintain the safest PO2. And this is mainly to minimize the leak from the face mask, and also the advice to perform rapid sequence induction and use video laryngoscopy to increase the distance between the operator and the patient. And they advised against the fiber optic intubation unless highly indicated, mainly to minimize the cuffing and bucking, and that's increase the process of generating more droplets. Positive pressure ventilation should be deferred until the cuff is inflated. The other emphasis also to maintain a closed circuit, so avoid unnecessary endotracheal tube disconnection or circuit disconnection. And when that's really needed or unavoidable, then the full PPE should be on, and also clamping the tube also on suggestion, and the ventilator should be on standby, and the HEPA filter was recommended to be attached to the tube. Disposal, resheathing the contaminated materials, and also we should have a sign on them, and then to be sent to either disposal, or if for sterilization, it can be sent to the CSSD. So doffing, so strict adherence to proper doffing steps. This is one area that we emphasize, and also for the hand hygiene and cross monitoring. So anyone who's doing the doffing should be monitored by another person. For the PPE, so this slide describes the basic principles in high hygiene and distance. That's the first layer that we use for protective equipment or strategies. And also it's got the goggles, footwear, waterproof gowns, and gloves. And for the mask, then they advise to have a fitted N95 mask, or if that's not available, or it can't be used in PAPR or air purifying respirator. So this just a show for the dunning process, someone is actually actively monitoring the other participant or other team members once they are putting the scarf in. You can see this lady is actually, because she will be outside, so she's not wearing the full gown, but in the doffing process, so she should wear it. This is the PAPR, so these also taken from the same article. So this patient, this participant here may not be did not have a fit test, so he's using the PAPR, or for the longer procedure sometimes. So, so this is for the general guidelines. Saudi Anesthesia Society also, I'm grateful, they have provided other guidelines as statements, and I will go on them briefly for the sake of time. So they published also a recommendation for pediatric anesthesia by our colleague, Dr. Al-Jahani, Dr. Zghaibi, and Dr. Harun and Assad. And it's almost the same general principle, and the slight variation here is just using IV induction if possible in pediatric, and also using muscle relaxation to minimize cuffing, and instead of uncuffed tube, using micro cuff if possible. Also, they recommended deep extubation if that is feasible. For thoracic surgery, also Prof. Dawlatli and Dr. Tahan, Dr. Abdul Mu'min, and Dr. Qattan, and Dr. Abdulaziz, they also gave us a good review about managing thoracic surgery in patients with suspected COVID. So they applied the same general principles, and the difference was purely using, if possible, disposable fibroscope rather than having the reusable one. And for the airway or for one lung ventilation, there was no specific recommendation regarding they can use blockers or any double lumen tube. Obstetric anesthesia, there was also a recommendation, and I will not go in detail because I think Dr. Ibrahim will cover this in the next talk, inshallah. And briefly, just talk about every minute an obstetric that counts, and time for proper doing sometimes not negligible. So the emphasis was purely on communication and proactivity. Ophthalmic surgery also, there was a report from Dr. Ahmed and Dr. Zahoor and also Dr. Abdulaziz and Dawlatli. Given that most of the ophthalmic procedures are under local anesthesia, so we applied the general principles, and they focused on actually the pre-operative screening and the process of categorizing the patient to high risk or low risk, whether we are coming to proceed or delay, and if we can use regional blocks or general anesthesia. So even electroconvulsive therapy during the highly contagious respiratory plan, there was also a paper from the Saudi Journal of Anesthesia by Dr. Schumann and Silberman. So because it may not be common in every hospital, but I know there's some hospital they do ECTs, and you might face a patient who actually COVID positive or suspected, and usually that creates a dilemma. So the advice here from the expert that apply the general principles that we talked about, and if we can do this patient in a negative pressure room, and patient should have the mask coming in, and we'll just do them in the from aerosol generating process, face mask, probably the least, and try to avoid using any supraglottic airway. For the CPR, also there was a task force by Dr. Khan and his colleagues, and it's almost similar to the other recommendation, and they omitted for the layperson giving a breath and starting with the CPR, and for the staff or in hospital, then using the proper PPEs and trying to use a HEPA filter attached to the ambu bag or resuscitators. So this is for the Saudi Society. For over the next 5 minutes, I'll just go about a few other society and guidelines for the statements for this pandemic or crisis that I find it useful. Dr. Tim Cook and his group also, they published a very good consensus guidelines for the managing airway in patient with COVID-19. And it's covered most of, it's almost similar to the general principles that has been described by our colleagues in the Saudi Anesthesia Society. And it's detailed here, but it's the same principle, nothing is different. They focused on safe, accurate, and swift. So safe for staff and patient, and accurate, not try to use something that you never used before or not familiar with, and trying to minimize the time in between using rapid sequence and not giving a high flow, or at least a high flow for aerosol generating process. They described also the process of how the runner will be outside the room and inside, and some ergonomics of having actually the patient and some setup, suggested setup. Dr. also had some recommendation and a very good review, and I found it useful. And this group from Adelaide in Australia, Dr. Wong and his colleague, actually they described in a very detailed, actually, the process of managing the airway, starting from pre-op screening, and also the difficult airway and different categories. And even they described the anteroom here and what instrument and required PPEs for every part of this one. So I found this one very useful. If you have time, you can go and Google it. This is also, they divided the patient into binary, low risk and high risk. And from there, this is, I find it useful because once you know the patient is suspected, then usually we'll go to the high level of PPE. But sometimes we have uncertainty. We don't know the patient is actually low risk or high risk, and that's what creates sometimes confusion. So I found this one is actually helping in the algorithm and differentiation in the daily work. This is a continuation. And then they also talked about the air change per hour for the OR time mainly. So if it's 12 per hour, then the time needed for efficiency is almost 23 minutes. While if you increase it to 50, then the time needed actually for clearing it will be 6 minutes. And from the Saudi anesthesia, it has been mentioned also in the pediatric that they increased the flow to 20. So that will give us almost 14 minutes for 99% efficacy. So this is a very detailed, so I will not go into a lot of discussion or time, but mainly this is for tracheostomy, because we do see a few patients that comes because of COVID positive and prolonged intubation. And it also guides the practitioner in actually making a decision, and a timing of the procedure that's found useful. So if we can delay the patient 14 to 21 days, which is slightly longer than what we are used to, just mainly for the viral load to be decreasing, that if possible would be helpful. For the previous, the previous slides, all talking about the recommendations and how can we do this paper from the Canadian Journal of Anesthesia was a prospective study. They actually reviewed the teams that they were assigned to do intubation during the pandemic and the peak. And it was a 7-week period. They did around 150 primary trachea intubation, and they analyzed it, and they found actually around almost 90% of their staff, they used video laryngoscopy, and there was 11% of their staff that probably got infection, or because they had to self-isolate because of COVID-19 symptoms. And there was also here some multiple anecdotal report of duffing breach, which is more than dunning. Okay. So earlier during the pandemic, there was a spread about aerosol and boxes and barrier enclosures, and some found it actually a very useful idea. But with as we go through the pandemic period, there were 3 papers that they actually did some simulation and found it. They advise against it. So this is Cervello, I think, from Italy, and then also another one from Japan and one from Australia. And they found it actually to prolong the intubation period, and also it might cause breaching of the protective equipment because of the damage. So it's not recommended. This registry from Dr. Karim Al-Baghdadi, so the risk of health workers following trachea intubation, or what is called the COVID intubator registry. So it's almost 10%, similar to the Canadian one. 10 to 11 subsequently develop symptoms despite having the multiple, or the full protective equipment. Okay. It's not only the infection, but also the occupational stress and the mental health. So this one from Italy, and they did a very good survey, and they evaluated the stress, insomnia, and anxiety and depression. And that's what they found. Around 71% of their staff actually reported high work stress, and insomnia 36%, and depression up to 51%. So that's something for the leader probably to think when managing the teams actually dealing with the COVID. So the summary, so COVID-19 up to, as of last night, almost 1.5 million deaths internationally. And this is from Statista website, and this is just the healthcare worker who died from COVID-19. So like in Mexico, that has the highest, and then United States. And this photo has been circulated over the internet. This is from Mexico because they had a lot of death there. They generated or combined this photo from a smaller photo of the staff that they lost, they have lost during the COVID period. So in summary, the organization, scientific bodies have done a great job, and I have to commend the Saudi Anesthesia Society for their great effort. And intubation in COVID, it's a learning process for our experience for all of us. And I believe after the crisis, the analysis of these cumulative data is likely to have a positive impact in our understanding of the performance, also the future for the airway management and the infection control. Thank you. Thank you.
Thank you, Dr. Abdullah. I thank the organizing committee for the invitation. It's an honor for me to be in the co-sharing this session. Our next speaker is Dr. Ibrahim Abu Shusha. Dr. Ibrahim is assistant professor and a consultant in anesthesiology and obstetric anesthesiology and critical care. He is a deputy director of critical care at the King Abdulaziz University Hospital here in Jeddah. He obtained American Board in Anesthesiology and American Board in Critical Care. Dr. Ibrahim also obtained fellowship in critical care and obstetric anesthesia from Harvard University. Dr. Ibrahim is going to talk about the obstetric anesthesia management in COVID-19 patient. Welcome, Dr. Ibrahim.
Sorry, it was mute. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Atif, for the welcoming and your nice words and introduction. First of all, I would like to welcome all of you and thank you all for being here with us in this Friday morning. And also, I would like to thank the organizing committee for giving me such an opportunity to present and be part of this wonderful group of anesthesiologists and this wonderful course. So today I'm going to talk about the obstetric anesthesia care during the COVID-19 pandemic. My overview of this lecture will be, I'll start with a brief introduction about the disease and some statistics. Management of pregnant women with suspected or confirmed COVID-19. I'll speak about the PPE during the obstetric anesthesia provided to the pregnant patients. And I'll take about some anesthetic consideration, and I will summarize at the end. So for the introduction, as we all know, late in 2019, in the city of Wuhan in China, there was a lot of report emerging about the severe acute respiratory syndrome that was called at that time SARS-CoV-2. Fast forward in February 2020, WHO termed the illness as a coronavirus disease. They called it COVID-19. And in March 2020, WHO declared the COVID-19 as an outbreak as in a global pandemic. Speaking about the current moment, we're up to yesterday, we're around 63 million infected patients around the globe. And here in Saudi Arabia, we're around 360,000 infection confirmed cases. I'll speak about some statistics. So these statistics, I looked into the data looking for Saudi related pregnancy statistic, did not find, I'm sure it's coming out soon. But I'm quoting here the United States from the period of January 22nd to November 23rd in 2020, just to give you an idea of the magnitude of the effect of COVID on pregnant patients. So the total cases were around 40,000 in this almost a year period. The total deaths for pregnant women were 54,000. The hospitalization was around 8,000, though the author mentioned that there is not a clear cut in any differentiation between the reason for admission. Is it for delivery or is it from other COVID-related complication? So the admission to the ICU was around 295 cases in the United States. The patient who required mechanical ventilation was 85. So it is not a small subject. It's involved a lot of people, around 40,000, 8,000 of them admitted to the hospital, 300 to the ICU, and 85 were mechanical ventilated, which is more than the regular statistic for admission for pregnant women. So the question that I will ask now, why COVID-19 and pregnancy? Why are we in SAS or SAS, Saudi Society of Anesthesia Society, or in this lecture, why are you choosing COVID-19 and pregnancy? Is there any difference between pregnant women and other peers that are not pregnant? So as we all know, when the pandemic started, a lot of hospitals, for the reason that was mentioned by my colleague, Dr. Abdullah, spars of PPE and risk of infecting the healthcare worker, and a lot of not knowing how is it transmitting, what is safe to be done. A lot of hospitals shut down their elective cases, and they were doing emergency-based procedure or surgery. But as we all know, obstetric patient or pregnant woman will continue to come. It's a natural process that will never stop, and they will continue to come, and nothing will prevent them from coming to the hospital. And we cannot tell them, go ahead, let's find out, let's save our PPE and then come back later. So we have to deal with it. That's one reason why COVID and pregnancy is special to us, and that's why we're discussing it. And the other question would be, someone would wonder, are pregnant women more susceptible to COVID-19 from the get-go? Are they, as a cohort of patient or subgroup of people, being pregnant, does it put you at a higher risk to acquire the COVID-19? So the data so far does not support that there is an increased risk of acquiring COVID-19 just for being pregnant. And it has been shown in multiple publications through China, US, Italy, and even local here. Next question will come to mind. Are pregnant women with COVID-19 that acquired the disease are more susceptible to increased risk of severe illness and requiring ICU admission and other measure over the other regular non-pregnant peers? So the data so far is supporting that pregnant women with COVID-19 are higher, they have higher rate of ICU admissions, mechanical ventilation rate, and deaths, unfortunately. So being pregnant, acquiring the COVID-19 would put you at risk of higher ICU admission, mechanical ventilation, and death. One would wonder, why is pregnancy put you at risk of all these three complications or increased severity of illness with this disease? And as we all know, as anesthesiologists or medical students or doctors, that we should all blame the physiological changes of pregnancy. But what specifically in physiological changes of pregnancy put them at risk of all these complications? So this is all speculation, and people are thinking, and nothing is proved, but they're saying it's because increased the heart rate. The pregnant ladies have increased heart rate from the get-go on oxygen consumption due to the baby. So they have lower reserve for oxygen. And it's due to decreased lung capacity because of the growing uterus in the abdomen. And it's because shifting away, the nature of pregnancy is shifting away from cell-mediated immunity, not to reject the baby, which is a foreign body growing inside the mother. So the body, God created us to shift away during pregnancy from cell-mediated immunity. And that's an important part of fighting the viral infection. And also for the well-known risk of thromboembolic disease, because as we all know, pregnancy is hypercoagulable state. Another question would come to mind is, does COVID-19 increase the risk of pregnancy complications? So if you are pregnant and you have COVID-19, does that put you at increased risk of obstetric complication? So the data has suggested that increased frequency of preterm birth and cesarean delivery. Now, is it because doctors or obstetrician does not know what to do and they're being proactive and advising for cesarean delivery or not? We will find out later on, as Dr. Abdullah said. After the pandemic goes away and we have more data to set and analyze, we'll find out what was the reason. But it's statistically significant that if you're pregnant with COVID-19, you will have increased risk of preterm birth and cesarean delivery. So another reason why pregnancy and COVID is special is the clinical presentation. As we all know, the symptoms of COVID-19 disease is very general. Fever, myalgia, malaise. A lot of them are non-specific, and a lot of them could be attributed to pregnancy and labor, to the state of pregnancy or labor. For instance, myalgias and diarrhea could be a sign of latent labor. Preeclampsia, if the pregnancy is complicated by preeclampsia, that can present with headache, shortness of breath, that could cloud the picture and mimic some of the COVID-19 symptoms. And also, if the patient develop chorioamnitis, which is not that common, but it does happen, the patient will present with tachycardia and fever that also will mimic the picture of COVID-19 and might delay the diagnosis of COVID-19. So in addition to that, women infected with COVID-19 might be asymptomatic. And because, as I said before, we have to receive them in the hospital and aid them throughout the labor process or cesarean delivery, they pose a huge risk on their partner, family, and the healthcare worker dealing with it. And just a general question, does the COVID-19 have a vertical transmission? Most of the data does not support that. There is a few case reports indicating that there is an in utero infection, but it's hard to pinpoint if this infection happened through the placenta or it happened after birth. There is some studies that tested placenta tissue and they found the virus in there. But the general consensus is it does not transmit vertically to the baby. Second portion of my talk today will be about management of pregnant women with suspected or confirmed COVID-19. So I was honored and humbled to be part of this, writing this guidelines from the Saudi Anesthesia Society. And as Dr. Abdullah said, it was one of the first societies to form task force in multiple level, like the Airway that Dr. Abdullah presented, in Obstetric, in multiple level to address the confusion around the COVID-19 and anesthetic services during the pandemic. This paper was written by Dr. Omar, my colleague, Dr. Nasser Tawfiq, Dr. Fatima, and Dr. Fahad. I learned a lot from them and I thank them for their time and effort. And I advise you all, if you did not read it, it's a quick read. It will give you a wonderful insight about the COVID-19 and pregnancy. I will be quoting a lot of my talk today from this paper and other papers. So in this paper, we discussed the higher level first before we discussed the clinical level. So there was a lot of recommendation to the obstetric departments and institutional leadership, because solving this problem is by anticipating and acquiring quick fixes rather than just reacting to it. So we discussed the importance of surge planning by putting a plan. What will happen if we are overwhelmed with cases? What will happen if we are low in staff because they're infected? We should all talk as hospital in cities and form collaborative work and network to transfer the patient if needed. We also advise for the manpower to protect the healthcare worker, and they are the highest priority for us to save them, because if you lose a healthcare worker, you eventually will not be able to treat patient. We suggested some modification, physical modification, like bringing HEPA filters if for the aerosol generating procedure, opening modification in the rooms to make it negative pressure room as close to negative pressure room as possible if we can. And some access control to the L&D by preventing visitors and family members to reduce the chance of them getting infected and healthcare worker and other patients getting infected. Then recently it was published by the ACOG, the American College of Obstetrics and Gynecology, a guideline, an algorithm to how to when to test for pregnant patient with suspected COVID. So I'm going to present it here really quick. I apologize for the busy slide. I know it's not readable, so I'm going to zoom in and I will take it from there. So it all started with assessing the patient symptom and exposure. So we should ask the patient about their regular symptoms or common symptoms for COVID and their exposure to known cases. If there is no positive answer to this quick screening, it's routine parenteral care. If there is any positive answer, then we have to do the testing, and we should conduct illness severity assessment. We have to assess the severity of the disease, like any difficulty in breathing, inability to continue on a sentence, hemoptysis, anything that could indicate that this is a severe disease. If any of these are answered or positive, then we have to refer this patient immediately to emergency room or ICU or equivalent unit to deal with this pregnancy with what looks like high severity COVID-19. If there is nothing positive in that, in this questionnaire, then we go to assess for clinical and social risk. Then we ask about the comorbidities of the patient. Are they hypertension, diabetic, asthmatic, HIV patient, kidney diseases, and any obstetric issue in the past or in this pregnancy, and inability to care or arrange for follow-up. Some patient will have some social boundaries that will prevent them to present to healthcare facilities. If anything is positive, then we should refer them to moderate risk as in ambulatory setting, or admit them or arrange for that. And if it's low risk, then it's just routine regular care. Third part of my talk will be about personal protective equipment, and we all know how important personal protective equipment to prevent us from acquiring the infection and to protect our patient and our colleague and family, because it's not only the healthcare worker. The healthcare worker also at the end of the day will go to his or her home, and they have family there, so also they are at risk for acquiring the disease. So what type of PPE? In general, and I apologize for the repetition because Dr. Abdullah mentioned some of what I just about to say, but I will try to be quick in it and not repeat a lot. So in general, it is a droplet contact precaution, but we have to upgrade to airborne precaution in case of any aerosol generating procedure like intubation or extubation. This paper by Dr. Bauer and her colleagues summarized the recommendation from the SOAP, ACOG, and SMFM, the Canadian Society of Obstetric and Gynecology, New Zealand and Australian, and the UK. So as you can see here, all of them agree, and including us, SAS, the SAS, that PPE should be droplet or contact, except for aerosol generating procedure, then it has to be airborne. For the neuroaxial analgesia, as droplet and contact for all of them, ACOG added airborne is preferred just in case. And we, in the SAS, think if there is a high risk of operative delivery, then we should wear airborne. For cesarean delivery, all of them, if divided on the high or low probability of doing C-section, if it's high, then airborne. If it's low and we're doing neuroaxial, then it should be droplet and contact. I'll speak about some anesthetic consideration. So as we all know, patient will present to us as obstetric anesthesiologist in either to have a C-section in the operating room or spontaneous vaginal delivery in labor and delivery floor. So in regard mode of delivery, there is no recommendation. It's left to the obstetric opinion. COVID-19 does not impact the mode of, or should not impact the mode of delivery. For labor analgesia, as we all know, it divided either neuroaxial or non-neuroaxial. So for the non-neuroaxial, nitrous oxide or patient-controlled analgesia, as we can see here, a lot of authority, including the Saudi, the SAS, advised against or advised to suspend the operation of nitrous oxide for the risk of spreading the virus, considering it as a aerosol-generating procedure. Remifentanil and fentanyl advised against as a PCA for the risk of respiratory depression and need to instrumenting the airway, or due to the opioid-induced nausea and vomiting that will help in spreading the virus. In regard hemobate or carboprost, they also advise against it because of the risk of bronchospasm and needing to, for the patient then will cough or needing to instrument the airway. For the labor analgesia, that the other portion, then is it contraindication? The answer is no. COVID-19 in itself is not a contraindication to provide epidural for delivery. Early versus late, there is a lot of discussion, and most experts will advise to do early epidural just in case patient run into decels or needing to have an urgent C-section, then epidural can be activated and used as a method to perform the C-section. So for labor analgesia, we'll just discuss, we in our paper or algorithm, we divided into before, after, during, and after. So for before, cart location, if your institute has a cart for neuroaxial, it should be left outside the room. All healthcare workers should be wearing a mask throughout the procedure, even if the patient is asymptomatic. All patients should wear a surgical mask at all time, even if they're asymptomatic. And we advise for the paperwork to be filled outside the room after you're done with the procedure to decrease the risk of infection or capturing the disease. For during, who performs it, a lot of expert opinion, including us, advised for the most senior or most expert to do it to minimize the need for more people to go inside to help or save them, and also to decrease the time with the patient. And we advise to decrease the assistant to one nurse or one assistant, so minimize the personnel in the room. Assistant outside the room can be helpful to hand equipment, and afterward, Doffing is as important as donning because a lot of infection is from improper doffing. And this is just a summary to what I just mentioned. In regards to cesarean delivery, as we all know, it's either neuroaxial or general anesthesia. So for the neuroaxial, what type of PPE we already talked about, and we advise here to be airborne just in case we need to instrument the airway. For the spinal, epidural versus CSC, it's up to your discretion as an anesthesiologist. If you think that this will take longer than expected and spinal might not be enough, we advise to do catheter-based anesthesia like epidural or CSC. For general anesthesia, as a lot of it is discussed with Dr. Abdullah, I'm not gonna repeat it, but contact and droplet precaution, limit the number of people, should be performed by the most senior and should be performed as a rapid sequence induction. HEPA filter must connect it to the Y piece for even from pre-oxygenation, minimize the disconnect of the circuit, use video laryngoscope to decrease the time and increase the distance between the provider and the patient face. And if disconnection is needed, please apply clamp. If extension is needed, always think about it in ahead of time and attach it before the induction. Regarding extubation, the risk with extubation is actually higher than intubation because intubation is a controlled setting. You give paralytic, you give opioid to suppress cough response, but with extubation, you need the patient to be awake. So there is always a higher risk of for the healthcare worker into acquiring the disease. So we have to minimize the personnel. Anyone not doing anything in the room related to the extubation should leave the room while extubating. There is some report about IV lidocaine before extubation to suppress airway reflex. It's not a robust data, but somebody mentioned it and some people does it. Immediate and proper disposable of everything that has patient secretion like ETT, suction, and orogastric tube is of a paramount importance. PPE again and doffing is an important part and follow the guidelines of your hospital. For transfer, we added that the filter, excellent. I'm almost done. The filter has to be there all the time, the HEPA filter to the circuit. Non-intubated, we have to wear a mask. And we pointed that healthcare workers should be aware of their environmental services like doorknobs, elevator buttons, and to be accompanied by a security officer to help that. And also we advise for team debriefing to improve the system and the process. So in summary, this is just a picture from a paper by Dr. Herman, summarize what I just mentioned. Thank you very much. And sorry for taking a longer time.
Thank you, Ibrahim, for this excellent talk. And now coming to our third speaker, our distinguished speaker, Dr. Abdulaleem Al Attasi, is a consultant anesthesiologist and critical care at King Abdulaziz Medical City, Riyadh. And he's the Deputy Executive Director of Peri-operative Quality Improvement Department, Ministry of National Guard Health Affairs, and the Director of Operating Room Service at King Abdulaziz Specialized Children's Hospital. Dr. Attasi, you're going to talk to us today about new norm pre-operative practice during COVID-19. Thank you, Abdulaleem.
Thank you very much, Dr. Fahad. To start with, I would really like to thank the society led by Prof. Ahmed Abdul-Mu'min and also the scientific committee led by Dr. Harbi and the members to be invited to this great conference. It's an absolute honor actually to share with you the peri-operative care with COVID-19. And I'm going to give it just a global look and go through what happened with us since February till now. So it's not going to be very deep a dive into the practices. My colleagues, Dr. Abdullah Alharbi, mashallah, tabarakallah, and Dr. Abu Shusha, both of them, they covered lots of it. So for me, I'm just going to take you through what actually we're facing now. And I'm considering the whole journey of COVID and surgery. So let's go and look into this picture. It always strikes me. I was thinking to remove it actually before the starting of this talk, but then I thought it's really meaningful. So for me, it defines the operating room the personnel, and the conflict with the social distancing and everything we learned about COVID-19, and how we keep the balance between staff well-being, the stress, and that our colleagues in healthcare in general that they're facing, not to interact infection, and also how to provide the best possible care to our patients by the availability of the expertise in a timely fashion. So by itself, it's a challenge. Now, let's go of what happened with us and COVID-19. How did it strike us as an institute in general, institute and the healthcare to start with. So you remember, I'm not going to repeat the things. In February, we started to hear the alarms basically in around us. In March, the real deal started with in Saudi Arabia, and then we faced the issues. And maybe it's not a big deal now, but let's remember March, let's remember April, the PPE availability, the surgical mask availability, the N95, the PAPRs. How many of us did not have a PAPRs? I believe I called many institutes and they did not receive it as of yet. Some of the institutes received it just 2 months ago. The N95, as we speak in my very hospital, we still count them by them one, and we still look into just keeping them in a safe place and not to utilize more than one per 24 hours. The staff training, it has been addressed by my colleagues in the previous talks, and what we did in order to make sure that the compliance is very strictly covered, and the tools that we used in order to improve the doffing and donning and everything else, such as simulation drugs. Dedicated OR. We heard, as you, Dr. Abdullah Alharbi, he looked into how many times that we cycled the room air in the operating room, and what's the differences, and how we can minimize the equipments. And that's also covered by Dr. Abu Shusha. The ventilation system, and shall we go negative pressure or positive pressure, and what's the impact, and shall we use HEPA filter? And that, I'm sure that's addressed in every hospital across the country. The tracing registry for the patients who had surgical intervention and they interacted with COVID-19 as an infection, and the role of IPC. And definitely the patient journey and drawing it, and how is the patient going to reach the best the OR and back from the OR, and as the transportation has been mentioned by Dr. Abu Shusha. These all things that we looked at and we kind of addressed in a rush last February, last March. But did this disappear or not? That's the question. So probably let me talk about our institute. And we had the real hut in May, and after that we started to think about how we are going to de-escalate and what we need to do. So in order to do this, we went up in the focus from, and luckily that's what was played very well, mashallah, tabarakallah, with the command center and the Ministry of Health. So you think about your institute as a hospital, you think about the region and where you're at in which category in terms of the level of impact of the COVID-19. And then you think about the nation and the surrounding countries. And luckily we did this in a very nice fashion. That's why, mashallah, tabarakallah, in the last 2 weeks, our numbers are great. I can tell you that we are, all regions are the green zone, except one region is in the yellow, and the trajectory is very, very positive. So we're actually doing very well based on the way we managed, thanks to the high authorities in the Ministry of Health and all the other players across the nation. So the staff and the patients, the beds capacity, and let's, sorry, I'm gonna just do this so I can read. Yeah, so the staff and patient safety. Many of us remember that we divided the OR teams into 2 and 3, and those groups in order to minimize any interaction. And if some groups exposed to COVID-19, we can isolate immediately and keep the safety protected. The beds capacity was a major thing. Many of our hospitals needed to switch regular floors into critical care beds. And we had, as mentioned by Dr. Abdullah and Dr. Ibrahim, we need to stop elective business completely. And then the case mix, as Dr. Abu Shusha said, we cannot stop obstetric. They're just going to keep going. So what we are going to do with those? And definitely the supporting services and the supply chain related to this. A big question, and I think this question is still there. I actually threw this question yesterday to the executive level and the corporate of MNGHA, and we still don't have a great answer for it. Do we do COVID-19 swab for everyone? And do we depend on the acute respiratory infection tool? And what is the balance? My personal impression is the ARI what matters, and then the COVID-19 is a supporting measure. And why is that? You will all remember this study. It was published in JAMA. I think it was in March, if I'm not mistaken, March 11, 2020. And this is when they looked into different results from different specimens from those who interacted COVID-19. And what's the positivity of the test? This is what they found. We need really to keep this in our mind. So 75% tested positive when you take a sputum sample, around 63% tested positive when you got a nasal swab, and 30% got viral positive test from the PCR from feces. And this is where our colleagues in surgery felt the heat, because it's not airway, it's not anesthesiology only, it's actually coming to them. You do laparotomy, you might get the virus. And if you remember that a lot of pressure had happened after this study. Now, how do we interpret this result? So I found this study, and actually it was published from UK, and it's very, very helpful to make us understand what does COVID test results means. So for every 100, if you and that's based on what we have now. The pretest probability is around 80%, and the sensitivity is 70%, and the test specificity 95%. So if you say that from 100 you have 80 people who actually had the virus, and you test them all, you're gonna get 56 with a positive test. You're gonna have one who had a false positive. So the test is very accurate from specificity perspective. That's why it's 95%. But there are false negative of 24. And that's very important to keep in your mind. So if somebody have the symptoms and you want to reconfirm this with the test, and the test gave you positive, that's confirmation, right? And then you're going to make a decision to postpone on or deal with it according to the algorithm that you follow in your hospital. But if he tested negative, it doesn't mean that they have an infection. There are 23 people or 24 people out of the 100 that have the infection. And that's, you really need to keep this in your mind. While out of the 100 with the 80% pretest probability, there will be 20 people that don't have the infection. So that's why it's extremely important to go back to the basics of medicine, the history and the physical examination. And based on this, you decide for the testing. And probably this is not being followed. I know many institutes, they screen everyone. And then they decide about the procedure, yes or no. And this is where the challenge, we really need just to understand the limitation of this testing in prospect. This is not only in Saudi, this is across the world. There is challenges and implications of this false negative testing, and how much we trust that test, and how much we should trust our history of physical and clinical assessment for the patient, and how much we should trust our precautions that we take, and the strict adherence to those precautions in order to protect ourselves and protect our loved ones. Now, what's the impact? So I think Dr. Abdullah covered the anesthesia with the airway management, because that's very precisely anesthesiology level of care. And then Dr. Abu Shusha covered the obstetric, and that takes anesthesia and obstetric and gynecology care. And what about the surgical care? What's the impact of COVID-19? This is study that was published, I believe, in July, and it came in the Lancet, and it actually was striking. So it is it's a prospective. They looked into 235 hospitals in 24 countries undergoing surgeries for those who had a COVID-19. And the definition of those who got the COVID-19 is either 7 days before the procedure or 30 days after the procedure. And the primary outcome was the 30 days post-operative mortality. And they looked at the main secondary outcomes such as pulmonary complication, a defined pneumonia or ARDS, or unexpected post-operative ventilation. So what they found, the primary outcome was around 23%. So basically the mortality of this cohort was 23%. And what they found in terms of the secondary outcome in terms of respiratory complication, that actually those who had COVID-19 and got surgery, whether 7 days before the infection or 30 days after the intervention, the chances of having pulmonary complications was around 50%. Now, who's worse in terms of outcome? When they looked into their analysis, they found that those who comes through the emergency surgery rather than elective, those who are aging, precisely above the age of 70, those who have high ASA score, the 3, 4, and 5, and those who have a cancer rather than regular pathology. So, and that makes sense. But what's striking, the 50%, honestly speaking. There is another meta-analysis that was just published in October 2020. And they looked in around 2,500 studies, and what fulfilled their criterion was 47 studies. And again, the mortality for those who interacted COVID-19 post-surgical intervention was around 20%. And the chances of requiring ICU admission was around 15%. So it's not it's a real deal. It's really a real deal in terms of the surgical population in general. Now, let's think about beds capacity, because that's what we're going to come through. So we have 4 options, right? That's in every hospital. We either have the patients who come do the surgery and goes back home. We have the patients who come through day surgery facility, get the procedure, and then get admitted. We have the patients who actually admitted before the surgery, and we have this and requiring floor beds. And we have the patients who had requiring a higher level of beds, such as critical care or HDU. And to balance how many beds we have to care for our patients and the impact of COVID-19 in the hospital and the preparedness of the hospital is the biggest challenge. And probably most of us as hospitals, we reverted from admitting patients, and we went to the day surgery at the beginning and same day admission, just to minimize the utilization beds capacity and keep the most for those sequence. But as the numbers are declining, we are more reverting into providing capacity for our surgical population who's been waiting for almost 6 months now to get the care. So the case mix, a part of it discovered by the previous talks, thanks to Abdullah and Dr. Ibrahim. So the cancer care, when you look at the American College of Surgeons, they actually advised in March to look for alternative. But I think now is the time we should really proceed with their care. I know many institutes actually they never stopped. If they especially the tertiary and quaternary center, they continued with the cancer care with extra precautions that put in place. Time-sensitive cases, it's really hard to delay, especially when you come to specific populations such as a pediatric population, where you really need to intervene within time frame. Otherwise, the kid will have a significant sequelae. Obstetric care, Ibrahim mentioned, is straightforward and clear. We cannot stop. We just need to continue. Stage procedure is also hard to delay. The organ transplant, and this is a very, very particular population. Those are sick ones with end stage renal or liver or lung or heart issues, and they're also going to be immunocompromised. So on how you can protect them and do the procedure within timely fashion, and the elective procedures otherwise, as you know. So now I like this slide because it reminds us of what had happened. So remember when and during the peak of the pandemic, And it's still a peak in some countries, but not in our region, luckily enough, alhamdulillah. We had a major issue with the supply chain. We had a major issue with the regular medications not being available. And that impacted the anesthesia and back, of course, the chemotherapy and many other disciplines. The consumables, the implants and the regular supplies. We also had a major issue. I think it's getting better, but there are many hospitals still facing those problems. Now, the other supporting services, don't forget interventional radiology. They need to do the procedures, and these procedures are supporting our surgical population for diagnostics or for even care. And they also have their challenges in terms of how they protect themselves and protect and the anesthesiology support for those services and airway management and manipulation, how we are going to provide it in a safe fashion. And of course, the labs and consulting services during the pandemics. Now, from there, let's go. So we started with the journey with February, March, and we had to shut down. And then we started to think of our population, how we are going to slowly to de-escalate. And I think the question now today in every institute is how we can go back to full capacity. I know many institutes, they're back to the 100%, and how can they provide it in a safe fashion? And this is where the new norm is going to kick in, and just they are there to stay, to at least tell the vaccine, get into position, and we really get an accurate protection from those vaccines. I think the number one challenge in my eyes is the patient trust. I said it before and I will say it now. It's how we are going to convince our patients that we can do elective business with them in a timely fashion, and also we maximize their safety and we prevent any interaction or infection. Because actually, if you go back to the Lancet study, those who got the infection after the surgical intervention, they actually, those are the population who did worse, not the one we know that they have COVID-19. And this is by itself is a paradox, but it's a very challenging. And the ways against that, or with that, is just to having transparency. If you look in the West, every hospital, they have like a dashboard showing precisely how many patients of COVID-19 and what the level of care that they're providing to them, in order just to reassure the public. Educating material. I'm sure every institute across the nation, they provided infographics, they provided some pamphlets, and many of them, they provided some videos just to help reassuring the public and the patients. There were many ways of de-escalation, precisely by the American College of Surgeons. They had a roadmap or a readiness checklist. The NHS system also, they provided some pathways and checklists for the elective surgical procedures to be resumed. So this is the first slide that we had in the foundation part and in the beginning of the crisis, let's call it, the pandemic. And I brought it back again. And now let's think about it. So PPE availability, I don't think it's a problem. Maybe in 95 is not necessarily available in every institute. And that's why they're keeping an eye on them. Staff training, we should be okay by now, hopefully. Dedicated OR, I think this question is being raised everywhere. So we all dedicated one single room for the COVID-19, but now with the de-escalation and some institutes did not admit one single patient in a week or two. They're really thinking of the cost effectiveness and the resources that they have, and should they take this dedicated OR out and just dedicate certain time after hours, for example, for the COVID-19 patients. The ventilation system. Now, let me just allow me to touch base on that from operation perspective. So most of them, all rooms are positive pressure, and as Dr. Abdullah said, there is a time of cycles per hour that should happen. Now, switching to negative pressure rooms, that it is very possible, but it has a huge impact on the ventilation system in the future, and the maintenance is not easy to do. That's why many institutes reverted from doing this. And plus, by the way, it's expensive. So they kept the positive pressure and they added the HIPAA filter. And probably this is the best way in order to make sure the security is in place. Tracing registry still should be in, or written protocols for patient journey precisely with the COVID-19 should continue in. But, and this is my last slide, and I think this is what the new norm should be there. Many institutes, they use the scoring system, and they took in place the clinical patient status and how much is impacted by the surgical illness, the bed status, and the waiting time for the patient. At least I know in our institute, we actually applying, we started to apply a score that has to do with the COVID-19 at the beginning. And now we're applying another score just to look into the impact of waiting, the patient status, from clinical perspective, and how we can prioritize, because we had a 6 month of a lag of surgical care was not provided when we hibernated and waited to see the impact of the pandemic. Social distancing. I think the first question comes, how much compliance we have, and what are the methodology of monitoring that we have. For example, we did an audit across the corporate and NGHA around a month ago, and some of the hospitals were doing very, very well, and some of the hospitals actually the compliance was around 40 to 50%. How you are going to push back to adherence to the social distancing measures and the face mask and compliance and application and everything else. It is a challenge, because as you go by time, people, you know, it's always the tendency just to lag back in terms of adherence to those measures. If you're going to go back to full capacity, probably you need to think about redesigning the units and thinking about how many companions for the families that they should have, and whether what kind of precautions you're going to do for those companions. Should you test them? Should you not? What this is, I think, an ongoing question in every institute. Routine screening. Go back to the same question. The ARI survey, the COVID-19 testing, and the limitations, and how many times you're going to do this, because it is a process. And in order to prepare a patient for an elective procedure, it's a time consuming, and it takes between 3 to 5 days. And you do the ARI in day 0, then you book him in day 3. You need probably, and you test him in day 0 and day 1. You wait for the results, you reconfirm. Now this patient coming through winter season or fall and winter season to the facility, you need to reconfirm again, and how you make sure that the patient is fully prepared, and also he is not hibernating any infection. And in case you have a question mark, probably you need to have another tool, such as the rapid testing that gives you results 15 and 30 minutes. And do you have this availability of this resource in your hospital or not? And then the population that will have a COVID-19 and the surgery. And let's be very honest. If you hear that this patient had a COVID-19, yes, and he's in emergency surgery, it's kind of no-brainer. You're going to push this patient to the surgery and you take full precautions. But if you have a time frame that allows you to intervene, then are we really providing them with the care? Are we stigmatizing this population, and are we delaying the care? And how you can keep the balance, and how you protect the patient and protect your staff? It's a big question, at least for those who are inpatient and in the hospital. For those who are not in the hospital, when do you repeat the test? I think there's a new article came out in October, and they recommended not to repeat the test if you can wait for 6 weeks. And if you have to push the surgery between 2 to 4 weeks, probably this is the time to do the testing. But what if the testing, the results was positive? Now, is the patient shedding live viruses or not? And we know that within 10 days from the symptomatology, or 3 days after recovery, probably the likelihood of having active viral load is extremely low. But how you reassure yourself and you reassure the staff and the patients? This is a big question, and I'm sure there are many studies going on in order to address this, and we're going to have a more concrete answer compared to the today. So these are things that we need to think of. And my conclusion before I'm finishing, because this is my last slide, I really think we need to back off what we've done over the peak of the pandemic. And we need to think about how to sustain those measures and how to have a sustainable resources in terms of supplies, testing capability, rapid testing capability, and how to protect our patients from who, especially who interacted with COVID-19, and do them within a timely fashion. And finally, how to improve their outcome, because as we know, for this specific population, the mortality is 20% and it's to 23%, and this is really significant worsening of our outcome. And with that, I will conclude. Thank you very much.
Thank you, Dr. Attasi, for this is great talk, and thanks, colleague, for an excellent presentation. Before start questions, I just want to confirm that the next session will start, inshallah, 10:30 with our colleague talking about obstetric anesthesia. So we'll start with a question. We'll receive a few questions. So, Dr. Atif.
Yeah, thank you very much for all the wonderful talk. I will start with Dr. Adil Bhatti questions. He's from King Faisal Hospital in Riyadh, and he's obviously a COVID-19 airway response team. One of the challenges we faced was when we came across difficult airway in COVID-19 suspected or confirmed cases in ICU. Obviously, it is not easy to assess airway before intubation, difficult and critically ill. The help is not easy to get because of the helper takes time to arrive. They have no to do dunning themselves, and then they come. As far as I am aware, there is no guidelines on that. So I think this question is for Dr. Abdullah Alharbi.
You're mute, Abdullah.
Okay, thank you. So thank you, Dr. Adil, for this question. This is a very common question that we face it from our colleagues who are actually in the front line. I don't think that we will have a concrete or solid answer. We have some basic principles. So if you think you are in danger, that's what we do. And even BLS, if there is a danger, then we try to protect ourselves and then start to resuscitate the patients, doctors, ABC. It comes sometimes to some of the ethical question, how long you can wait, what about the availability? So it will be hard, but it will be also, what is the risk? So if someone has already contacted the virus before, and then he's doing the airway and he comes and say, it's not a general answer that I could say. It's individual, and balance the risk and benefit, and try to save yourself, because if you save yourself, then you can save more patients. And the airway in Saudi Anesthesia Society, they just focused on the preparing and planning. So probably having like a kaleidoscope, having some of the basic instrument will help you in the intermediate situation, rather than going with a simple laryngoscope and then getting or asking for more help. So probably that's what I would advise.
Thank you, Abdullah. There is a question regarding the conference material, the manual. So inshallah, at the end of the conference, we will have our recommendation and the conclusion of the conference, as well as all the lectures will be inshallah videoed and accessed. So this is regarding the manual of the conference. Question for Dr. Ibrahim regarding the managing a patient coming with a prolapse cord for stat C-section, how we manage the airway.
So excellent question. I think the question was what anesthetic, what are you going to do rather than managing the airway, if I'm not mistaken, you know?
Yes.
So it's an excellent question. As a lot of difficulty we face in life, I think you will weigh the risk and benefit. If you have a time to put a quick spinal, I would do that, and make sure also the patient has, since the patient has a respiratory symptom of surgical mask on. while somebody else is either donning to be ready to do to manage the airway if you're donning. If you have time, I would don myself with the PAPR or N95 from the get-go. Try to put a quick spinal. If it's not allowed, if it's difficult, or if I cannot, I would always be ready to just do a general anesthesia and be ready for that. If you don't have time, you are a priority, so you would wait, don properly, and then manage the airway while somebody is holding the cord and putting the patient in the bag, of course. Excellent question.
Thank you, Ibrahim.
Thank you, Dr. Ibrahim. Another question for Dr. Ibrahim is the risk of transmitting the virus during spinal neuraxial block. Any information about that?
So as was well said in this, a lot of information we don't know. We're still at the tip of the iceberg. We will find out more. But to my knowledge, there is some report from China that detected the virus in the CSF when they obtained samples. But I'm not aware of any case presentation or case that it is from the like the patient acquired disease from doing spinal or epidural. I think, and also there is a lot of reports that saying that the virus itself invade the CNS tissue, either directly from the nasal passage and from the opening in the skull above the nose. So the virus is there. It has been detected even prior to spinal. But how important is that clinical? I don't think any cases or any strong evidence suggests to avoid or not to do a spinal epidural.
Thank you, Ibrahim. There's a question for Dr. Attasi. Are these recommendations for de-escalation goes along with return to elective surgery guideline by Saudi CDC?
Thank you very much for the question. Honestly speaking, I think so, because after all, by the way, it's all preparedness on spec, because we don't have enough concrete data. So it is speculation, but we need to realize that and actually get proud of one situation that we're becoming a leaders in terms of how much publication and how much work and as healthcare providers in Saudi Arabia for preparedness for COVID-19. And actually, you all heard that the mayor of California, he's basing his precautions on 3 countries' studies, and one of them Saudi Arabia. So overall, there is no right or wrong. I think what we're doing is goes along with the CDC, the Saudi recommendation itself. But you need to. The guidelines are generic, Jama'at al-Khair, and if you allow me, and we always need to base it on our resources and within the institute, because we have a different capacity and capability and different the scope of surgical population and interventions. So it's a balance among all, I would say.
Yeah, another question. Thank you. Another question I think is for Dr. Abdullah. Is regarding the use of LMA in a short procedure as opposed to intubating with the intratracheal tube.
Thank you. That's also a good point to raise. So in terms of the aerial report that published about the managing the airway, they talk about the ranking, actually the AGB or aerosol generating process. The intubation is the highest, LMA is the second, and using a face mask is the least. So this is the way they escalated. So most guidelines, they recommended not to use the LMA. So they are afraid of provoking a cough. And also with positive pressure ventilation, you might also have some spreading continual. So it's either using the face mask or the tube if you have to intubate to have the cough inflated. Dr. Tim Cook, in the second review, they actually wrote a detailed paragraph about this one, and they compared it with some simulation, and they classified the LMA also into 2 groups. So whether we have risk factors for aerosol generating or not, and then they put it as a low risk. So it's a hard actually to say yes or no for the question, but if we can think that the patient is not going to cough, the patient is deep and it will be more deep, probably it can be used. But if there is any chance that the patient would be light, then or just trigger spasm, and you have to use positive pressure ventilation, then going to the basics, so either face mask or intubation probably safer.
Thank you, Abdullah. I think we are coming at the end of our session. We'd like to thank all our colleagues, our audience who's participating in this conference, as well as our distinguished speaker for an outstanding lectures. And hopefully we'll see you in 10 minutes or 5 minutes for our next session. Thank you all, and see you around.